This is part 3 of your urinary disorder lecture. My apologies, I'm having technological difficulties. We left off with nursing care and the importance of nutrition, hydration, in particular water, and the importance of frequent voiding every 2 to 3 hours. We're now going to move into voiding dysfunction, and in particular, we're going to talk about incontinence because this is a lecture that's geared towards the female client, and female clients also tend to have a higher rate of incontinence due to childbirth, vaginal childbirth in particular, or the presence of an episiotomy. Now, there are many different types of incontinence as outlined in your reading and here on this slide. The three that we could talk about before we talk about stress incontinence, which is the more common phenomena that, or diagnosis really, that women will talk about, especially those who've had children. But when we talk about other types of incontinence, we have to at least address the presence of neurogenic incontinence, which we see typically in our clients who are suffering from some sort of neurological impact and function of the bladder. So good examples of these might be the patient with MS, the patient who suffered from a CVA. Dementia actually can be considered a pathological reason for neurogenic bladder. Diabetes, damage to the tissue in the bladder, in Parkinson's. Another type of incontinence can be the spinal cord impacted client. So we have that degenerative or traumatic insult to the spinal cord, which can contribute to incontinence, or the non-neurogenic, and meaning that there's no spinal cord involvement, no neurological involvement. There's simply conditions that impact voiding, and your textbook talks about the bashful bladder. And these are folks who, it could be psychosomatic, we're not exactly sure, but who actually may have some issues that are more behavioral surrounding their voiding. Overactive bladder, so the bladder is just, and you'll probably all know somebody, right, who has an overactive bladder. And again, this can lead to incontinence. Post-operative, the effects of general anesthesia on the bladder can contribute to some incontinence. And then there it is, stress incontinence. And stress incontinence is the development of incontinence or leakage from the bladder that's related to either pelvic floor muscle, the inability for the bladder and sphincter to respond in a way that is tightly regulated due to the impact of prior deliveries and damage to vaginal wall or vaginal tissue. So there's that risk factor, pregnancy and delivery. Menopause, again, the hormonal changes in the vaginal canal can decrease sensation. Anyone who's had a history of any kind of GU surgery, genitourinary surgery, immobility can contribute to stress incontinence because we lose some tone. And then the high impact exercise, and we're talking about runners do have a higher rate of stress incontinence, as do cyclists have a higher rate of incontinence and UTIs. Cyclists can have a higher rate. Obesity and cognitive disorders, so again, not being aware and then experiencing incontinence. So treatment for incontinence typically focuses on behavioral modification and exercises or training. And these are Kegels. I mean, we've talked about Kegels more than once this semester. You've read about them more than once this semester. We teach it in the prenatal population. We teach it in the postnatal population. But really, in general, females should be performing Kegels long before they have children and long after. If the incontinence is significant enough, the female client may require med management like an anticholinergic, which will decrease the need. Anticholinergics have a drying effect, right? So anticholinergics, a tricyclic antidepressant, something like an amitriptyline, could be prescribed, We know that their research does show that it has some effect on incontinence. Hormone replacement for the menopausal woman could be a consideration if there's no risks, or actual surgical interventions, which are limited and last resort. Your textbook does cover those. There are some procedures that can be done that will sometimes using mesh or to support the bladder. We can sometimes see that as well. So some other voiding dysfunctions that are covered in this chapter that just to briefly touch upon, urinary retention. The topic of urinary retention is the inability for the bladder to void. For these folks, sometimes they'll use a diuretic to help the client with the urinary retention. Urinary retention is not exclusively a female condition. It's actually often seen more in males because of the prostate. So we won't go into depth on the urinary retention. Your textbook also talks about that neurogenic bladder, which we already discussed a few slides back, and then moves into catheterization and the conditions surrounding catheter-associated UTIs or CAUTIs, as we know. This is reading that you should have covered in 112. Remember, anything you've learned prior to this, we always apply. We go from, we are a educational program that builds on previous knowledge. So make sure you do review your catheterization readings and notes to be aware of proper catheterization techniques and minimizing any CAUTI risks. Urolithiasis and nephrolithiasis, which are stones, is covered in 212, and the lithotripsy and those kinds of procedures that are used to cover renal stones. Trauma is mentioned in this chapter as well, which is covered in 212. And finally, the cancers along with diversions. So cancers are typically addressed in 212. It is considered a condition, an advanced condition of the medical surgical client. And diversions, technically you should have read on diversions for 112, and that's basic stoma care. So for this lecture, you would not be held responsible for the cancers nor for the stoma care that would be surrounding the bladder cancers and those types of urinary diversions, that the ileal conduits and things like that. Those will be covered next semester in 212. And I think that is it for this lecture. Thank you very much.